Hello everyone, welcome back to tutor series. My name is Shujauddin and in today's lecture we're going to talk about membranous nephropathy. So membranous nephropathy belongs to the group of nephrotic syndrome, and what happens in membranous nephropathy is that you have thickening of your glomerular capillary walls, and along with that you have subepithelial deposits of your immune complexes. Now when I say subepithelial deposits, we're going to talk about the glomerulus here and we're going to see what do I mean by subepithelial deposits. So let's say that this is your endothelium, right? The blue line is resembling your endothelium. Then you have your glomerular basement membrane that is being resembled by the red line, and then the black line is going to tell you that these are your podocytes, right? So when I say subepithelial deposits, I mean deposits between your podocytes and your basement membrane, right? So if I were to deposit immune complexes here between the podocytes and your basement membrane, these would be called subepithelial deposits. Now, if these are subepithelial deposits, what would be subendothelial deposits? So subendothelial deposits would be between your endothelium and your basement membrane. So yeah, these black circles are deposits that are subendothelial in nature. So this is something that you need to understand before we go into membranous nephropathy. So what did I say? In membranous nephropathy, you have thickening of your glomerular capillary walls and you have subepithelial deposits of your immune complexes, right? And it comes under the heading of nephrotic syndrome. So there are a few associations that can cause membranous nephropathy. So let's have a look at that. So the first association would be idiopathic, right? So you could have the disease due to an unknown cause. So idiopathic is going to be the first thing. Apart from that, a few drugs can cause membranous nephropathy, such as your penicillamine, your ACE inhibitor, that is captopril, and NSAIDs can commonly cause membranous nephropathy. So these are going to be the drugs. Apart from the drugs, you have association with a few carcinomas such as lung carcinoma, colon carcinoma, and melanoma. So these are a few associations with membranous nephropathy. Apart from that, patients who have SLE can develop membranous nephropathy. Patients who have SLE can also develop nephritic syndrome, that is lupus nephritis, but we're going to talk about that when we in the video of nephritic syndrome. But patients of SLE can develop membranous nephropathy. Patients who have chronic infections such as syphilis, Hep B, Hep C, so these patients will be at risk of developing membranous nephropathy. So Hep B, Hep C, and syphilis. Apart from infections, patients who have autoimmune conditions such as autoimmune thyroiditis can also develop membranous nephropathy. So autoimmune conditions will also be a risk factor. Now, the pathology behind membranous nephropathy is that in membranous nephropathy, you basically have a production of an autoantibody against an antigen and a self antigen that is present inside your body. So basically, on your podocytes, if I were to draw a podocyte, so this is going to be your podocyte, right? On your podocytes, you have a receptor that is your phospholipase A2 receptor, which is also known for PLA2 receptor for short. So on your podocytes, you will have phospholipase A2 receptor, also known as PLA2R. Now, if you have an autoantibody inside a person against your phospholipase A2 receptor, what will that antibody do, right? If you have an autoantibody against this, what will happen? That autoantibody is going to come to this and it's going to destroy it. Now, when they're going to destroy it, what will happen? You're eventually going to destroy what? You're going to destroy your podocytes. So what will happen in a membranous nephropathy, along with increased thickness of your glomerular capillary wall and immune complex deposition. And what would be the immune complex deposition? It would be because of this. Your autoantibodies are going to come, they're going to deposit there, and they're going to destroy your podocytes. So you will eventually have what? Effacement of your podocytes in membranous nephropathy. Like we discussed that in all nephrotic syndrome diseases, you have damage to your podocytes one way or the other. So in membranous nephropathy, how do you damage your podocytes? Through autoantibody production against your phospholipase A2 receptors that are present on your podocytes. So this is how you're going to damage your podocytes in membranous nephropathy. So now, what would be the clinical features in a patient that has membranous nephropathy? So since this is a type of nephrotic syndrome, what will you have? You will have proteinuria. Now that proteinuria is going to be different from minimal chain disease but similar to FSGS. Now think about it, different to minimal chain disease but similar to FSGS. That would mean that this proteinuria is going to be selective or non-selective? Non-selective. That means you're going to lose not just albumin but also other proteins as well. So this is going to be a non-selective proteinuria. Apart from that, you will have hypertension present in such patients. But hypertension might be minimal, might not be there. So it's going to be a 50-50 chance, right? It's going to be 50-50. Apart from that, you can have hematuria. In patients of membranous nephropathy, you can have hematuria. Apart from hematuria, there are a few things that are present in membranous nephropathy that might tell you about the severity of membranous nephropathy, right? I mean, it could be mild, it could be severe. So how can you know that whether it is a severe kind of membranous nephropathy? I mean, how can you track the progression of the disease? You can track it in 4 ways. The first one is going to be development of hypertension, severe hypertension. Apart from hypertension, you're going to have raised creatinine levels. Raised creatinine levels, hypertension, and you're also going to have hematuria, massive hematuria. Like, these are a few things that are going to be present, and these are going to tell you about the progression of the disease, whether the disease is severe or it's going to be mild in nature. So hypertension, raised creatinine, hematuria are a few things that will tell you about the progression of the disease. But since it's a nephrotic syndrome, you will have edema, proteinuria, hypertension. Proteinuria is going to be non-selective in nature. Now, coming on to the morphology, that what would be the morphology. So we're going to discuss the morphology on the 3 things. The first being light microscopy. What would you see on light microscopy? You're going to see increased glomerular capillary wall thickness. So glomerular capillary wall thickness is going to increase. On light microscopy, this is something that you will notice on light microscopy. On electron microscopy, what you would see is that I'll draw the diagram over here in much more detail. So this is going to be your endothelium, that is resembled by the blue marker. The red marker is going to show you your glomerular basement membrane, and the black marker is going to tell you about your podocytes. Right, so these are your podocytes over here. Now you will have immune complex deposition, right? Now this immune complex deposition is going to be subepithelial, right? We talked about here that it's going to be subendothelial, that is between the podocytes and your basement membrane. So you will have the deposition in multiple segments. So it's going to be like this. You will have deposition here, then you'll have a break, then you'll have deposition here, then you'll have deposition here. So this is how you will have the deposition. Now what's going to happen is that the basement membrane is going to grow, it's going to keep depositing, it's going to increase in thickness. How will it increase in thickness? It will increase in thickness in between the 2 immune complexes. That is, these are the 2 immune complexes. The basement membrane is going to grow here. Then the basement membrane is going to grow here and it's going to grow here likewise. So in between the spaces of two immune complexes. Now what's going to happen is that, like if I were to make more space here, like let's say this was your porocyte, yeah. Now these growth of your basement membrane is basically resembling spikes. There's a spike here, there's a spike here, and there's a spike here. In between you have nothing, there's a flat thing. So this is going to be the first thing, formation of spikes on electron microscopy. The second thing is going to be that these two spikes are eventually going to join with each other. Just like this, it's going to join over here as well. So what you're seeing is that you have spikes, and this growth is going to resemble a dome, right? It's going to look like this: dome, spike, dome, spike, dome, spike, dome. Like this is how it's going to be there. So on electron microscopy, you're going to see something that is very specific to membranous nephropathy, that is spike and dome appearance. Like that is pathognomonic to membranous nephropathy. So spike and dome appearance. And how is it going to be spike and dome? Spikes are going to be the basement membrane growth, and between the two basement membrane spikes you will have a dome formation, and it is going to be the overgrowth of your basement membrane above the immune complexes. So this is how you will have spike and dome appearance, and it is going to be visualized on your electron microscopy. You're going to see this on your electron microscope. So you'll have a spike and dome appearance. Apart from that, on electron microscopy you will also see thickening, sclerosis, that is also going to be present. And yeah, one thing, by sclerosis, when I mentioned the progression of the disease, one thing that you need to remember is that increase in sclerosis will also tell you about the progression, whether the membranous nephropathy is getting worse or not. So keep that in mind, that the fourth point is increase in sclerosis. Now coming on to the morphology. So on electron microscopy, I explained here that you will have a spike and dome appearance, and that is really specific to membranous nephropathy. Apart from the findings on electron microscope and light microscopy, on immunofluorescence you will see the presence of two things, that are IgG and C3, your complement protein. You will have the presence of IgG and C3 that you will see on immunofluorescence. So like I mentioned earlier, on the basis of these three investigations, that is light microscopy, electron microscopy and immunofluorescence, you will have these things that you will, on light microscopy you'll just see increased thickness, and you'll also see effacement of your podocytes. You will see effacement of your podocytes on electron microscopy as well. So apart from the spike and dome appearance, you will see podocyte effacement. And on immunofluorescence, you will see the presence of IgG antibody and complement C3 proteins. So these are the things that you would see on membranous nephropathy. Membranous nephropathy also does not respond to treatment, that is, they do not respond to steroids. So keep that in mind, that they will not respond to steroids. So giving steroids is not going to be a solution for membranous nephropathy. The only disease that responds to steroids is going to be your minimal chain disease. So this was a brief overview of membranous nephropathy. So we talked about the association, clinical features and morphology in a bit of detail, but it was brief. So if there are any questions, feel free to write them down in the comment section or reach out to us on our Facebook page. Thank you for watching.